After that exciting session, Jagopal, actually, I was looking all this time for is SGLT2 something to do with the arousal? And it is fortunate. I also found out that there is a study by Eric Mayo saying that it improves the erection in rats. Maybe. Now, back to your dapagliflozin story. Now, it's always fascinating to see the inextricable relation between diabetes and heart failure. Heart failure is the most important preventable and treatable cardiovascular complication. And the presence of heart failure in patients with diabetes is associated with an increased risk of death, obviously. Conversely, the presence of diabetes in both forms of heart failure increase the risk of cardiovascular events and death. So the relation is inextricable. Well, this is heart failure is a major and growing public health problem all across the globe, and we are not different. This is the data from our own country, which shows that 5-year mortality, the Trivandrum heart failure registry is results showed more than 56% death in about more than 3 years of time. So we needed over the years. We have been treating our heart failure patient with RAS blockers, beta blockers, and MRA till in 2014 when we have a new compound in the form of angiotensin lipolysin inhibitor, which gave us another 20% reduction. But even then, the residual risk of heart failure is still huge. But then came the SGLT2I saga, and of course, it started all with data, which was not a heart failure study, but then showed a substantial reduction in heart failure, and every gliflozin in that group gave us a very, very promising result in the form of reduction of cardiovascular death and morbidity in the form of heart failure hospitalization. Now, when we look at the DAPA-HF data, this is we have about 4,700 patients. I'm sure most of you would have gone through these data. The important point was it was a very simple trial. Unlike the ARNI trial, it was not confusing. We can just simply give him a dapagliflozin, no escalation, de-escalation. And interestingly, more than 50% of the patient in this trial did not have diabetes. That's very, 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 very interesting. Look at that. So you have only 42% of these patients in the DAPA-HF trial being diabetics. The baseline, you could see that it was basically a combination of class 2 and class 3 heart failure. And otherwise, the control group and the clinical trial group was matching in every way. This is very important because all the patients recruited in the DAPA-HF data trial have an excellent optimized background therapy. Look at that, almost 94% of them have been, on some RAS blocker. But the only possibly thing to be worried about this was the percentage of patients with heart failure getting ARNI was only about 11%. But diuretic 93, beta blocker, another huge proportion, 96%, MRA, 70%. So excellently managed heart failure. And look at the primary endpoints. So both in the diabetic group and the non-diabetic group, it gave a very fascinating and impressive reduction in cardiovascular death, which was about 18%, and hospitalization, which is about 30%. So very, very impressive results and very fascinating results also. Every hospitalization for heart failure, hospitalization for cardiovascular death from any cause, you say any indices of morbidity or mortality, it was there with a very impressive percentage. And if you look at the pre-specified subgroup, every group benefited, whether it didn't matter, the class 2 or class 3, whether they are from Asia or other part of the world, whether you are any race. So every subgroup benefited from dapagliflozin. That also, the basically one of the cutoff point, the EGFR cutoff point was less than 30, but you could see here both the groups with renal dysfunction CKD and without CKD benefited from dapagliflozin. It not only reduced the recurrent hospitalization, even the first hospitalization, the repeat hospitalization, which is one of the real bane of heart failure treatment, was considerably reduced by dapagliflozin. And here again, one could see that now, regardless of the BNP level, it could improve the results very well. That also is applicable to the regardless of the blood pressure. Of course, you could see here the cutoff point was basically kept, even though kept as 90, it was anything more than 100 was okay, and it doesn't matter whether you are an obese or otherwise. The impressive result was there to see. So also the secondary endpoints of all-cause death, which was similar to the earlier gliflozin data, that DAPA gave us almost 17% reduction in the cardiovascular, the total deaths. And all these excellent results at the expense of very few adverse events. That is something which very, very, very impressive about this is, you could see that none of these adverse events were very impressive. And the discontinuation rate also was very, very, very low. So one could surmise that the benefit observed was on top of the excellent background therapy. The only hitch being the RNE percentage was a little lesser. And look at the results. The curve started, the Kaplan-Meier started separating rapidly initially, and it continued there. If you look at the NNT, it was only 21 for the risk reduction, for the mortality risk reduction. So over and above the RNE, we have a drug which will give us excellent results in improving the morbidity and mortality of heart failure. And this time, all across the HbA1c level, it was giving us excellent results. The most important additional factor being, it also prevented the development of diabetes, which is again something which is something which we can eagerly wait for. So what the SGLT2 DAPA has done is a formidable task of improving outcome in heart failure with reduced ejection fraction on top of the existing 4 pillars of heart failure. That is ACE inhibitor, ARB, beta blocker, and MRA. So this could be, as Deepak Bhatt said, it was a momentous victory in the war against heart failure. So citing that the 5 pillars of heart failure. So despite the grim pandemic situation, I think at least the heart failure with reduced ejection fraction guys has a very fantastic year in the form of DAPA, which is again going to be a very fruitful in the realm of heart failure management. We have never had this opportunity to have so many good drugs which will improve the morbidity and mortality of heart failure. Thank you for your kind attention.
Thank you, Dr. Mohan, for a wonderful presentation. A couple of things. I think the first thing is This data has really shown us something to look up to in terms of treating heart failure with reduced ejection fraction. But what about heart failure with preserved ejection fraction? I mean, it's believed that the SGL2 inhibitors may not have that kind of role in heart failure with preserved ejection fraction. That is number one. And secondly, also, on the if you see, all these patients were very well treated, and as you're rightly shown, 95% of them were on ACE or ARB, 92% on beta blockers, and then quite a significant percentage on diuretics as well. So the only concern is when you add this, some of them might get dehydrated, and though we have seen a lot of renal safety outcomes, do you think if you use an SGL2 in the initial stages, this will create a problem? And where do you position it? Like, you add an ACE inhibitor and ARB immediately, MRI within the first 1 week of heart failure. So where do you place it as an add-on? So these are the two things which I wanted to ask you.
Yeah. The first question now, what about the preserved ejection fraction heart failure? We have to wait for the data from the Emperor. Possibly we're going to see the Emperor preserved soon, maybe by the end of this year or early next year. And that will give us an idea about whether SGLT2I as a group will give us, has its role in preserved one. That's number one. Number two, as you said, see, with the new therapy comes the new opportunity to treat more number of heart failure. That's all. Kindly note, this SGLT2 DAPA was used on top of the existing 4 pill list. So our first initial treatment is patient on beta blocker, MRA, and ARNI, or any of those ACE, ARB. On top of it only we are contemplating. We definitely, of course, with one trial we started using ARNI, almost similar fashion. I can say that from the Empire trial we have no questions about its value, but as you said, it has to be individualized. The first thing that I will give is the neurohormonal blockers, and then only I will put them on SGLT2I.
Thank you.
So let me invite Dr. Poonam Malhotra, who is chief of cardiac anesthesia, and she is basically internist and a physician as well. And she heads the ECMO and LVAD program in All India Institute of Medical Sciences. And she would be speaking today on ECMO and LVAD in LV dysfunction.